Hello, my name is Vlad Ratziu. I'm a hepatologist at Sorbonne Université, working in Paris, France. And today I will present you the new nomenclature for steatotic liver disease, why it was done, and what it will achieve. So, steatotic liver disease is now becoming a very prevalent disease, especially in the Western, but also in other parts of the world. It is part of the metabolic phenotype, but is insufficiently recognized, diagnosed, and managed. It is no longer an academic curiosity, and there are many stakeholders, including industry and private organizations that grant a lot of money for research into this disease. And we do need a coherent nomenclature in order to cover all aspects of the disease. So those are the main reasons why it is a timely moment to do this new classification and nomenclature. And the problem we do it is that we have a certain number of problems that we're facing if we keep the old nomenclature for this condition. It is a non-based definition, meaning that you define something by what it is not, which is not something that is desirable, scientifically speaking. There is low awareness for this disease, particularly in patients with metabolic risk factors, since this is not part of the current definition. It does not categorize sufficiently people with different aspects of the disease, such as lean NAFLD, secondary cause of steatosis, dual cause of steatotic liver disease. It ignores the epidemiological reality of the overlap with alcohol consumption, meaning the requirement that there is no alcohol consumption in the definition ignores a whole part of the population that actually has shared the risk factors for steatosis. It increases heterogeneity instead of decreasing it by not clearly specifying what it is about and what are the pathogenic mechanisms that drive the accumulation of liver fat. And therefore, it does not receive sufficient funding or sufficient awareness. As an example, non-communicable diseases have 17 times less funding than HIV, which is a clearly distinct and well-recognized and well-named health condition. So therefore, there is poor understanding also on the patient side and reluctance to engage management of this disease with the healthcare providers. And an example of how this affects the perception of the patients is shown on this slide here. The fact that there is a certain level of confusion in the name creates trivialization of this disease, does not increase awareness of this disease. Patients are not taken care of in a holistic manner because the metabolic aspect of the disease is ignored in the current definition. And all this results in poor quality of life and, in fact, in less access to health services, less management of the disease, and consequently, an increased disease burden. Now, the term non-alcoholic stems from the fact that early observations have shown that it has the same pathological image as alcoholic liver disease, but it does not convey the concept that this condition is, in fact, very strongly connected with metabolic comorbidities. The term nutrition-associated, which was also a term that was proposed some time ago in order to have a better word than non-alcoholic, actually ignores important disease modifiers, which are not all based on nutrition, which might be genetic, for instance. It is an excessive simplification because it's not all about what you eat in this disease, and also puts the blame somehow on the patient by suggesting that this could be a self-inflicted disease, while the pathogenic reality is much more complex than that. So the key point here is that recognizing the metabolic dysfunction as the major disease determinant is particularly important. Insulin resistance and NAFLD are very closely linked. Adipose tissue dysfunction is one of the main sources of fat buildup in the liver and inflammation in the liver. The presence of metabolic risk factors is a very relevant metric for understanding the prevalence of the disease, its severity, for understanding its oncologic transformation in hepatocellular carcinoma, and for reducing disease heterogeneity if the disease is based on the presence of the metabolic risk factors. Also, it anchors the liver injury in the metabolic phenotype, which might improve detection and awareness of the disease, might improve linkage to care and treatment, and it is also will simplify the implementation of targeted activities such as awareness, prevention, management. And it's also easier to talk about this disease and to engage with healthcare authorities or funding third-party payers if you really understand what the disease is part of. It identifies more severe patients because we all know that the more metabolic dysfunction you have, the more metabolic risk factors, the more severe the liver disease will be. And the defining parameters for metabolic risk factors have already been largely determined and defined in the cardiology metabolic literature. So the first important step toward a better definition nomenclature of the disease was taken in 2020, where a very large panel of experts, international panel of experts, had determined a new classification that recognizes the importance of metabolic risk factors that should be part of the definition. And you can see here this publication, which is a seminal publication by Jacob George and his group, that tended to redefine the presence of the disease based on presence of a certain number of metabolic risk factors. Now, several criticisms have been raised against this new classification, which are listed here. The concern about the validity of the process, meaning basically that this was a consensus of only a subgroup of experts and not an officially mandated process of change by the scientific societies. The impact on disease awareness and stigma might be not entirely removed especially by keeping the term patty in the title of the disease. Drug and biomarker development might be impacted by the fact that the definition changed and included a more liberal use of daily alcohol consumption, and by the elimination of steatopatitis as a pathologic entity. There was lack of clarity on metabolic dysfunction, and the adaptability to the emergence of new disease phenotypes as determined by future research might not have been optimal with this classification. So keeping all these limitations in mind, there was clear need for a new nomenclature that would specifically convey underlying disease drivers, basically metabolic dysfunction, that would be non-stigmatizing for the patient in all languages, that would account for the role of alcohol to a certain extent, especially moderate amount of alcohol, that will be able to parse out all specific etiologies leading to steatosis and classify them into the new classification, and that could have the ability to allow adjustments driven by new discoveries in science and in clinical medicine. So one important distinction is between the classification of the disease process and the definition itself of the disease. And those are not entirely overlapping things. They are not entirely synonymous. So the first thing is to define an affirmative set of diagnostic criteria for steatotic liver disease and no longer an exclusion set of criteria. Then what we need to keep in mind if we revise the definition is to have to err on the side of being inclusive, not let any patient out that would have only minimal or incipient or minor form of the disease. The third thing would be to minimize it as much as possible patient heterogeneity, but also to be adaptable to future insights that discoveries might bring us. The definition should be simple, readily available throughout the whole world, and should rely on easily measurable parameters. The diagnostic criteria should be selected in such a way as to align with already existing definitions, already existing measurements of cardiometabolic risk factors that have been well established and well validated in other disciplines. The set of criteria for adults would need also to be adjusted to the pediatric population. So with all these requirements in mind, several international scientific societies have convened panel of experts to devise the new nomenclature and the new definition and to submit it to other experts, a larger panel of experts of 264 individuals, including patient groups from all the societies that are sponsoring this project, from 56 different countries, as shown on this map, through a Delphi process in order to have the most complete agreement and consensus on the output of this new nomenclature. And you can see on this slide here some of the members of the steering committee, and all these people are highly expert in their field, as you can see from their publications and the impact those publications have had and continue to have. So the methodology of this Delphi process was a iterative submission of statements to the voting members of this very large 264 panel of experts and patient representatives. And each new round would be adjusted based on the answers and the comments on the previous round. And this is how you end up with 4 different rounds of questions. And throughout this process, a certain number of statements that received a very high consensus, as defined here on the left part of the slide, would be kept in the next iteration, and all the others that did not receive sufficient consensus will be either discarded or transformed, modified in order to have a better consensus. And this was publicly discussed at least on two occasions. One was in July 2022 at an international ad hoc meeting in Chicago, and the second one at the Liver Congress in Washington, D.C., at the American Association for the Study of Liver Disease meeting. Now, there are some areas where there was very strong consensus among the 264 voters, and those are very important areas for the definition of the disease. First, the role of alcohol. It is clear for everybody that consuming amounts of alcohol that are not excessive, but that are above the current threshold, that is part of the current definition, meaning 20 and 30 grams per day for women and men, clearly alters the natural history of the disease and may also alter the response to future drugs. Another important thing people all agreed is that this moderate consumption of daily alcohol, if combined with metabolic risk factors, should be an independent category because it has additive deleterious effects on liver injury. Another aspect that received a very large consensus is that if someone goes beyond a certain limit, which was fixed at 60 grams per day of alcohol consumption, that becomes almost an entirely new, different disease, which is alcoholic-related liver disease, whether or not metabolic risk factors are associated, and that deserves a special category. Therefore, any combination of these alcohol consumption with the presence of metabolic risk factors should need to be determined in relation to the amount of alcohol and the presence of these metabolic risk factors. And people who drink moderate amounts of alcohol should be in a category of their own and should not be ignored in the future classifications. The other thing that was consensual is that the term steatopatitis, in particular, the pathological form that it represents, meaning liver inflammation, liver cell injury, coexisting with steatosis, deserves to be kept because steatohepatitis clearly has prognostic implications. In particular, it is the main form that drives fibrogenesis in the liver. And therefore, NASH resolution, meaning the reduction in the activity level of steatohepatitis, should remain an important classifier of disease activity and therapeutic efficacy. The disease classification has also brought some important consensual points, which is that people with steatosis but without metabolic risk factors should be characterized separately. Those are usually secondary causes of steatosis, and we'll come back to this. And then the term metabolic dysfunction highlights a central aspect of disease pathophysiology and therefore deserves to be in the definition of the disease. There were also areas of moderate consensus. For instance, the names NAFLD, NASH are sufficiently flawed to warrant consideration of a name change. So at least 3/4 of panelists agreed that the name should be changed. And then almost 80% agreed that an overarching umbrella term should be used that encompasses the different categories of steatosis based on etiological factors that are underlying. The impact on clinical trials was considered to be negligible if a change in definition would be done away as outlined before. So this is what the nomenclature ended up with, an umbrella term that covers the presence of excessive fat in the liver. So that is called steatotic liver disease. And then depending on the underlying etiological factors, different categories. If there are metabolic risk factors, and we will see how those are defined on the next slide, then the disease is called Metabolic Dysfunction-Associated Steatotic Liver Disease, in other words, MASLD. Within this category, there can be either a full-blown steatohepatitis or just some level of steatosis without inflammation, without liver cell injury, which is called simply MASLD. Now, if there is excessive consumption of alcohol, then we're clearly into what is called alcohol-related liver disease. If there are specific causes that explain the presence of steatosis, then we are in a different category which encompasses specific etiologies of steatotic liver disease. It can be drug-induced, it can be different rare monogenic diseases, it can be a lot of other environmental exposures that drive fat accumulation in the liver. Sometimes we don't find any cause, and that's clearly cryptogenic steatotic liver disease until new discoveries might orient towards a specific cause. And then there's the big category of patients, at least epidemiologically, of patients that have metabolic risk factors and yet drink amount of alcohol that are above the limit, but not excessive. So moderate consumption of alcohol. So this is the MAFLD category, which is the innovation of this new nomenclature system. And that covers people who drink between 20 and 30 grams per day, up to 60 grams per day, excluding 60 grams per day, so up to 50 grams per day. And it is very difficult to know in these category of patients whether the metabolic risk factors or the alcohol have the most weight in liver injury, in generating liver injury. And it's probably something that is entirely dependent on the individual. It's very difficult to assess. But in any case, there is a new category created for this very important group of people, epidemiologically speaking. Now, how does that fit with the old NAFLD definition? It turns out that there is almost complete overlap between the way MASLD is defined and NAFLD. And one of the advantages of this new definition is what used to be called lean NASH is now almost entirely covered by the MASLD definition. So there's no more need to say lean NASH, it's all MASLD. Now, there are some causes of steatosis that cannot be labeled neither NAFLD or MASLD, and those are the secondary cause of steatosis. There's a very good review of the secondary cause of steatopatitis that has been published in the Journal of Hepatology, and I refer you to this publication in order to know all of these secondary causes that need to be looked for before establishing the diagnosis as being MASLD. Now, regarding the interaction between alcohol and metabolic risk factors, which is the justification for the creation of this new MAFLD category, here are two important sets of data, again, taken from a review recently published in the Journal of Hepatology. On the right side, you can see that the presence of visceral adiposity is something that clearly adds to the risk of developing severe liver disease, regardless of the amount of alcohol that is being consumed. And you can see on this right part of the graph here that patients that drink 40 grams of alcohol per day can have the same level of severe liver disease as those that drink only 10 grams of alcohol per day, if the latter patients have an increase in visceral adiposity. In other terms, if you have metabolic risk factors, drinking even less alcohol than what used to be considered harmful could end up in having more severe liver disease. And the same thing is shown on the left part of the slide, where you can see that regardless the amount of alcohol categories, moderate, heavy, or abstinence, the fact that there is metabolic syndrome, so metabolic dysfunction, increases the risk of having severe liver diseases during follow-up. So this is clear justification of the creation of this category here. The difficulty being, of course, to establish the thresholds. So for all practical purposes, what was decided is that a consumption of alcohol between 20 and 30 grams and 50 grams per day would be labeled moderate. Beyond that, it would be alcoholic liver disease. And in between, the important thing is to recognize the presence of both causes of liver injury, so dysmetabolism and alcohol consumption, in order to treat patients as well as possible and in order to categorize patients and not leave them into an orphan category. So to summarize all that, the current diagnostic flowchart requires that you first identify the presence of excessive liver fat. So that would apply for steatotic liver disease by any method, including different methods of imaging or rarely biopsy. When that is the case, what you need to do is to look for cardiometabolic risk factors. Are there any or not? If there are not, then you have to look for other causes of liver disease. If they are present, then you are in a specific category of secondary steatosis or steatohepatitis. If they're not present, then it's cryptogenic steatotic liver disease. Now, if the cardiometabolic risk factors are present and there are no other cause of liver injury, then that is MASLD. If there is alcohol or any other cause that is associated with metabolic dysfunction, then we're in a mixed category, a dual category. And the most important, epidemiologically speaking, of those dual categories is MAFLD. Now, how about the criteria for defining the metabolic risk factors? They are all listed here. Please see the fact that the pediatric criteria are somehow different from the adult criteria, and the adult criteria have been published here and have been proposedly chosen to align with the same criteria that are now being consensual in the cardiometabolic field. So does that change all the research results that have been generated so far before the new nomenclature change in terms of clinical trials or qualification of biomarkers? Just two examples to show you that no, that is not the case. In fact, the new definition encompasses most cases of NAFLD and also most cases of MAFLD previously described. And there are very few patients who do not have the criteria for metabolic risk factors and who would still qualify for NAFLD or MAFLD. And this was very nicely shown in a study from the Far East, from Hong Kong, involving more than 1,000 patients from the general population in which all metabolic risk factors were measured. Now, in terms of biomarker development, the same reassuring data has been generated by a large data set of patients who had liver biopsy and non-invasive biomarkers. This is a large multicentric French study that has shown that when the criteria are present in a patient record, it is extremely rare that someone that was labeled NAFLD would no longer be labeled the same way by the new definition because the metabolic risk factors are not there. In fact, only 1.6% of the patients that were labeled NAFLD would not be labeled the same with the new nomenclature. So there is almost complete overlap. And sometimes those metabolic risk factors in historical data sets are missing. Most of the time, it's not the BMI that's missing, but probably hypertension, dyslipidemia. However, when all of them are present, we only found one patient out of 1,369 who did not have any metabolic risk factor present and yet had steatosis in the liver unexplained by any other cause. So clearly speaking, all the research that was done in terms of biomarkers with the old definition can apply with the new definition. So this nomenclature and definition change was endorsed by more than 70 societies, which are shown here on the slide. And what we hope that this new definition will be implemented in the scientific publications and in clinical practice, and this will need to be conducted proactively. It was clearly the time to revisit the nomenclature, and the new nomenclature and definition, in our view, increases patient homogeneity by identifying the underlying metabolic dysfunction in these patients, and also allows the classification of a large epidemiological group with a dual disease that includes moderate alcohol consumption, as explained previously. The impact on biomarker trials is minimal, and the impact on therapeutic trials is also minimal. So we hope that this will help better identify these patients, increase awareness of the disease, and optimize communications around this disease. Thank you for your attention.